they shouldn't have is key. Today, what we'll do is we're going to go through that triage and history, how to really get out of the owners ask the right questions to get the right answers and find out more, because the pet can't tell you what they've eaten. When are you going to decontaminate? The indications, and when not to, and how are you going to decontaminate them? I'll go through some antidotes and enhanced elimination, and then we'll have a couple of cases to highlight a rodenticide and a chocolate poisoning with a couple of key take-home messages. So triage and history, and again, you'll hear me say it many times, stabilise them first. It doesn't matter what toxin they've eaten, you're going to use those same principles to get them stable. So your A, B, C, D, E. And during that time, you're treating them in life-threatening. Are they seizuring? Do they need to be intubated? All of those things are running through my mind with toxins. Don't forget to do a really thorough exam. Sometimes you get very easily sidetracked onto they've maybe eaten something when actually they've got something else going on. So that owner may sway you by their certainty that someone else has poisoned them. A neighbour who they're disgruntled with has poisoned them. That's a very common thing. And sadly in Australia, that people think their neighbours are out to hurt innocent pets, when truly I haven't seen a case where it's been confirmed that the neighbour actually poisoned the pet. And they'll be very adamant as well that they didn't eat anything, they don't have access to rat sack, and then you get out of them that they do have rat sack in the house. Dogs especially think rat sack is lollies, so if it's anywhere remotely near that property, they've probably eaten it. So high value questions is trying to get out of them what could have been ingested, when, how long ago, did they have access or left unsupervised? How much had you put out? So how much chocolate, how many grapes or raisins, how much rodenticide, how much rat bait is around? What are the current signs they've noticed at home? Did they notice anything pre-coming, what brought them to the vet? How long have they been noticing those clinical signs? What access? Have they moved everything? Have you moved the back? Someone's moved behind the fridge. They've had workmen here. Asking really these kind of targeted questions to get more information. Illicit drugs is a common one again in Australia, that the son had some marijuana or some, other Class A drugs, and the pets got into it. Everyone's kind of like, don't know where that came from, but it's come from another family member. The initial diagnostics, we'll often run a blood gas. We'll be checking for bleed. We'll get baseline blood. So often a PCV, TP, we're checking their glucose. So xylitol can cause hypoglycemia. We'll be looking at our electrolytes. Some of the different toxins can cause electrolyte changes. If we're worried about rodenticide or the patient is unstable, we're trying to figure out what's going on. We are going to have a quick look in their abdomen and their thorax with a ultrasound. If they've got tremors or arrhythmias and we're wanting to know what underlying rhythm is there, we'll do an ECG if you've got that ability to do it. And get a minimum database, so a biochemistry and a hematology. Do you guys have the human drug screening tests that you can buy from a chemist? We've got those. There's one hand there. I don't know whether that's just stretching. We have these in Australia. You can buy them over the counter, and they're great for testing if it's been marijuana, benzos, cocaine, amphetamines, all come up on this test. And sometimes we've got little dogs that come up for multiple of these, and they're all of the effects of stimulants can be going on in these little dogs, but at least we know what we're treating then. We're not here to disclose anyone to the police or get anyone in trouble, but we use these urine drug screens because we do, unfortunately, see illicit drugs in our pets quite commonly. Move on to decontamination, and this is something in human medicine where they don't really decontaminate anymore. Trying to actively make humans vomit can be unreliable. A lot of drugs, a lot of overdoses are intentional, so they've not been found in the time frame or not presented to a hospital in the time frame that they've already absorbed quite a lot of them. Are there early antidotes available in human medicine? They can put them on ventilators, they can do dialysis. And there has been large human studies showing no outcome benefit for a decontamination, and therefore it's rarely used. For us, why I feel this still really matters in decontaminating them, it's not because dogs absorb things slower, it's often what they've eaten stays in the stomach longer. Waxy rat bait, lots of chocolate in wrappers, lots of pills in wrappers as well. Any high-fat reasons why they may have delayed, they get into the bin and eat a heap of things, and there's got delayed gastric emptying, and you'll be surprised when you make a pet vomit, you ask the owner how long ago they ate it, and it's sometimes hours, and you've still got lots of chocolate and wrappers coming out. You're like, oh, even though it was kind of greater than what I technically think I should have in the time frame, it's quite rewarding, and you're going to decrease that toxin load in that patient. And dogs will generally pretty reliably vomit with apomorphine. Can you get easy access to apomorphine? Yeah, easy. Is it the tablet or the injection? Injection, okay, yeah, we can only get the tablet easily now. And often owners see their pets are with them all the time, and sometimes they don't see that they've eaten something they shouldn't have. But sometimes they do, so they can bring them in straight away. It's not a human who's intentionally trying to harm themselves and taking a big overdose of something without telling anyone. We do have limited access, to life-saving interventions like ventilation and dialysis, so it's always worthwhile decontaminating where you can. So it can be really meaningful in our treatment. The other key thing is, we don't decontaminate every patient. The key ones that we do is when there's been a recent ingestion and it's a significant toxin load. If they've just eaten a little bit of milk chocolate, you've got the Tox calculators now online that you can plug in their weight, what they've eaten, and it tells you whether it's a toxic dose or not. If it's not a toxic dose, we're not going to go and make them vomit unless that owner is unsure of how much they ate. If our patients are neurologically normal and they can protect their own airway, and there's no other contraindications of the type of drug that they've ingested. So, but as I said, not every patient requires decontamination. If they're already quite affected by that drug, coming in tremoring, altered mentation, seizuring, got no gag, they can't, we make them vomit, are they just going to aspirate? Different corrosive drugs we don't want to bring back up again and do even more damage to them, or esophagus and mouth. We're not going to try and make them vomit up really sharp objects. We're more likely to go in with an endoscope, or sometimes surgery is indicated. And if they're either unstable or got severe respiratory signs, we're not going to. So it's case by case. And that's the other thing we're thinking with decontamination. It's not just vomiting. We go on to then think of other ways we can minimise the absorption of toxin. So vomiting is number one. Gastric lavage, and it's something where the ability and the return on how much you actually get out. Vomiting, you get sometimes up to 60% of the gastric contents out. Gastric lavage, you may only get about 20%. So it depends. If it's a drug that is really, got a really high toxicity and they're already mentally affected enough that I don't want to make them vomit, yeah, sure. Getting them endotracheally intubated and flushing their stomach out with warm water and trying to get as much of that toxin out will be beneficial, but you've got to weigh up the risks and the pros and cons, because gastric lavage ones I've done, they're much more likely to make them aspirate once you've get them extubated, but normally the situation I would use it is if they're affected enough and needing to remain intubated, then sure, washing their stomach out, seeing if you can reduce that load at all. Activated charcoal, this little fella has been with getting activated just chalk tox, and getting activated charcoal into patients can be challenging. The nurses have some tricks with what food they mix it with. It can really help with any, I'll go through the indications for activated charcoal next. The other thing we can do is we can try and enhance, slides are moving through by themselves a bit. We can enhance elimination with diuresis, which we don't do forced diuresis really anymore, being careful with fluids and not over-hydrating these patients. We've got to keep them with normal hydration. And intralipid therapy is another big one. If you've got a lipid-soluble toxin, we do use a lot of intralipids, and I've got the list of drugs that we'll use them for. So complications is they can aspirate if we're making them vomit. If hypernatremia, sometimes we've had owners who've used salt slurries and they've come in massively hypernatremic and then can actually be dying of that, where the toxin that they wanted to try and make them vomit for and gave them a heap of salt wasn't actually lethal, but now they're dying of their hyponatremia. Activated charcoal depends on the brand that you have, can have a high salt content as well, so repeat dosing can be concerned. Again, we're giving, if you're using alpha-2 agonists, so medetomidine to make cats vomit, cause hypotension. If you're using bicarb soda or washing soda crystals or salt or hydrogen peroxide, H2O2, they can all cause gastritis and esophagitis. Be very careful. I don't recommend even to owners to try and decontaminate at home. I've seen more harm than good with those. So most effective method is to do it early. You can get up to 40 to 60%. Ideally, if the toxin's been ingested within an hour, we'll definitely go up for multiple hours, even sometimes 4 or 6 hours if they weren't sure. The amount of times I've had a lot of chocolate and wrappers come up, or as I said, pills that have been still in their pill. Some of them have been crunched up, but some of them are still in their wrappers. In dogs, we use apomorphine, and cats, we use medetomidine, and avoid home remedies. This is a pretty spectacular vomit you've all probably seen. Easter for us is a big time of a lot of chocolate, and also all the festive periods where people are having barbecues and dogs are getting into all sorts. So for us, apomorphine, and as I said, xylazine or medetomidine in cats, and we don't recommend hydrogen peroxide or washing soda crystals or salt slurries. This is a little dog who the owner had actually given a salt slurry to, came in with a sodium greater than 200 and seizuring. So yeah. For us, apomorphine, we only get it in the little tablets, so I look up your drug formula for the IV dose. We used to get it years ago. I always remember we'd write the box on the dose rate on the box because it was a funny long dose rate that you couldn't really remember easily. But dose to what the drug formula recommends if you've only got the IV one. Otherwise, we use it subconjunctivally, where we'll actually put it in their conjunctiva and it'll slowly absorb. Sometimes to get it to work better, you kind of move their head a bit, make them a little bit dizzy, and they seem to vomit a little bit better after doing that. So we've gone through this before. If there are reasons that it's contraindicated, sorry, that's a double up on that slide. And if you've got any toxins that are really strongly acidic or alkaline, we're not going to use it. Gastric lavage, again, 20%. There's a tip here is actually having them angled slightly down. If you are going to do this, you're going to have a cuffed ET tube and you're going to have suction ready. Activated charcoal just seems to go everywhere, and I've had patients aspirate activated charcoal whereas aspirating a little bit of water is probably better for the lungs than activated charcoal. So we wait till they're recovered and awake before then getting them to take in activated charcoal. So for dermal or ocular contamination, so pets that we have pest control people in Australia, and sometimes their licensing leaves a little bit to the imagination with what they actually know with those toxins. I had a pest man who dunked his cat in a pyrethrin-based product and came in seizuring, and those cats that have accidentally got their whole coat covered, we really need to wash them, and the dishwashing liquid is kind of the most stripping, I find. Using a dishwashing liquid can really help get their coats cleaned. If anything, a patient has got anything corrosive or toxic in their eye, really a lot of flushing. Some toxins, and in humans as well, we had one of our ICU nurses get an ammonia quad, a disinfectant, splash in her eye. Our ophthalmology team there came and helped us. I had started flushing with just 10 ml vials. They grabbed a litre of saline, cut the end off, and had hemostats on the end just to give a nice flow. And they put litres through her eye, and that's actually saved the eye. So really a lot of, you want a lot of flushing if you're going to have anything in eyes. Activated charcoal, it's going to absorb organic toxins. We're going to repeat if intrahepatic recycling or meds that are released slowly, or if there's delayed gastric emptying. We give with a little bit of food, trying to get it into them. The drugs that it doesn't bind is xylitol, ethylene glycol. So we have antifreeze in Australia that we commonly see. Any heavy metals, hydrocarbons, or alcohol-based products. Oh, so we are going through, sorry, I've got some double ops in there. So types of antidotes, we want any chemical antidotes, so antivenom, which we'll get into in our snake talk. Any functional, so intralipids, or if we've had huge doses of benzodiazepines, are we going to reverse that with a reversal agent? Or accidental overdoses of opioids, are we going to reverse that with opioids? So think, is there a drug out there that I could be giving to reverse this toxicity? If they've got into rodenticide, are we going to be giving vitamin K? And yeah, with some of your atropine is a reversible as well. To diuresis, if we're going to be doing enhanced elimination and doing fluids furosemide, they don't really recommend forced diuresis for many drug toxicities now. You've got to be very careful with fluid overloading these patients. Iron trapping, I haven't really heard of. Hemodialysis is definitely coming forward, so non-steroidal toxicities. There's different drugs that are able to be dialysed out, ethylene glycol. If you can catch these before the damage has been done to the kidneys, you could dialyse these drugs out of these patients. There's case reports coming out in JVEX, the Journal of Veterinary Emergency and Critical Care, showing huge successes with these patients. Intralipids for lipophilic toxins, and we use intralipids for us are reasonably cheap, about $200 for a vial, and we're using that in toxins that it's indicated for. The mechanism of action for intralipids, there's a few different reasons they kind of give out there. This lipid sink, is it trying to bind to the toxins and pulling them out of tissues? Is the lipids, an intralipid actually providing cardiac support to the myocytes and improving cardiac function and contractility, and the patient is actually able to better cope with that toxicity? Is there redistribution from vital organs and more of a clearance of it? They don't really know the exact mode of action of intralipids. We kind of know it works in certain toxins. There's also there's a log P of your lipophilic, and there's now a log of distribution as well, which depends how the toxin is distributed. So it's an area which still I don't think we'll really know, but we give it and it works. Adverse effects are really rare. I've never had I never say never, I'll go and get one now. I've never had a reaction to intralipid while giving it. We still kind of treat it like a blood product. It can easily get bacterial contamination, so we have a dedicated line. We don't disconnect, we don't inject drugs through it. It just goes in one IV catheter, and there's a dose which will, it's like online you can find, I should have put it in here, but the dose is, they get a bolus and then they get a dose at a rate over an hour. A normal size kind of Labrador ends up getting the full bottle, 500 mils. So the indications to use it is when you've got a lipophilic toxin, severe clinical signs, the patient's really quite affected. It's not just a mild toxicity. And standard treatment is failing. Sometimes in unknown toxicities, if I'm not sure and the owner is committed, we actually will try a dose of intralipid, because you see they quite commonly, if they're going to improve, they can improve within 1 to 2 hours post getting it. It can be quite dramatic. I've had dogs on ventilators, given them intralipids, and I'm suddenly able to get them off and extubate them. This is the list of the common drugs that we use it for. But again, if you get something that they've ingested, go and look up whether it's lipophilic or not, and there's generally, the list is online as well. So our initial goal of decontaminating that patient is to actually never see them get clinical signs. So we try and get rid or decrease the absorption of that toxin before it affects them. We'll go through a couple of cases. So Rocky was a beagle, 6-year-old male neutered, presented with lethargy, dyspnea, had pale mucous membranes, repeated lethargy there, inappetence, and had a hematoma from the previous venipuncture site at the referring vet that hadn't clotted. Owner was certain that the rat sac was in traps and that Rocky couldn't get it. When we did a little bit more investigating, we had a pleural and pericardial effusion. The ACT was slightly prolonged. Well, not slightly, it was quite prolonged. On our bloods, we had anemia. He was tachycardic and tachypnic. That was actually at the referring vet, and they'd sent him across to our hospital for a referral because they weren't quite sure what was going on with the pericardial effusion. He had probably did a PT, APTT. He had slightly low red cells and his total protein was down, so we were just highly suspicious he was actively bleeding. This was his chest x-ray. You could see the lung lobes are leafing, got a glassy kind of appearance. Something's happening in that bottom of the chest. So fluid is up the top of our list that there's something in there that shouldn't be there. And when we quizzed the owner more, that rodenticide, even though they thought he couldn't get it, generally when they say if they've got it on their property, we know those dogs are into it. The mode of action of rodenticide is it actually blocks the ability of the vitamin K epoxide reductase, so you can't actually get the final bit of your clotting factors to become active. You need vitamin K for that final bit. So the vitamin K can't be recycled, and that's where you end up with all these clotting factors going around the body ready for that final step, but there's no vitamin K to take them to active factors. So factor 2, 7, 9 and 10 are your vitamin K dependent factors, and they can't function. Your PT's got the shortest half-life, so it goes the quickest in 6 hours. And once those clotting factors are depleted, so you get a few days into this, the rat sac doesn't just happen in a day or two. It takes a couple of days for all of those factors to be depleted. And you can get uncontrolled bleeding pretty much anywhere. They present if they're actively bleeding, they're lethargic, they're weak, they've got pale mucous membranes, they can have pleural, they can bleed into their lungs. So if you ever see a dog that has an alveolar pattern just in one side, and I've had this before, medicine vets come to get my opinion on the x-rays, and just something in the back of my mind, I was like, have you checked a coag on that dog? It's like, oh no. We checked that, and that patient was actively, had access to rodenticide and was bleeding into the lungs, not just around them. The abdominal distension, so heme abdomen, that's quite a common presentation with them. They can be coughing up blood. They can have any sign of blood in their urine, melena, out of their nose, bleeding from their gums. They can bleed into joints. There's a case report of a dog bleeding into its spine. They can get upper airway obstruction. They can have a laryngeal, thymic or pharyngeal hemorrhage, intracranial or spinal, that tracheal dorsal membrane. And I've got an x-ray of that coming up to show you, because once you've seen that once on x-ray, you won't forget it. So Rocky got some treatment. We gave Rocky oxygen. We gave fresh frozen plasma because we were worried he was actively bleeding into his pericardium, where we don't have as much leeway. And this was back actually, the slide advancer has just got a mind of its own on this talk. The vitamin K, we now can get IV vitamin K, which works, it's sterile, it works, we've got a lot less risk of reactions than given the coagulon IV. So back when this is a few years ago, we didn't actually have IV, so we gave it subcut. And I give the higher dose of vitamin K as my first dose. I just want it in there, and then I'll drop back to that 5 mg per kg divided daily. As soon as you can give them oral vitamin K is very well absorbed with a little bit of fat. So a fatty meal, a bit of peanut butter, something into them. But if you've got injectable vitamin K and you can get your hands on the IV formulation, we now find we've got a lot less need for actually even having to give them plasma or blood products. That gets their blood clotting very quickly, the IV vitamin K. We avoid doing any invasive procedures unless they were in pericardial tamponade. And we're going to keep monitoring our coagulation once we've got the vitamin K into them. We want to see that normalise. This is the brand that we now can get in Australia of sterile IV vitamin K. We give it very slowly over about 30 minutes. And we have a very good response to IV vitamin K now without as commonly needing blood products in these rodenticides. So it's something we're already short in India on access to blood products and FFP. I definitely find out if you can source this over here. So my key take home from Rocky is if you've got pericardial effusion, always check your coags. And if you've got a rodenticide toxicity, go looking for blood where it shouldn't be. Go do an AFAR. Go have a look with an ultrasound and see if you've got pericardial effusion. This is the dorsal membrane that I just wanted to show you an x-ray of. If you've got a patient struggling to breathe, you take an x-ray and you can see this narrowing of the trachea. Ask them about rodenticide. This dog has bled into the dorsal tracheal membrane, and it is like it's treating them with the antidote with vitamin K and oxygen, and some of them have needed to be intubated, and we have them intubated for generally 1 to 2 days, as their body will reabsorb that blood. But it can be this is life-threatening. We've had dogs arrest from this bleeding where they shouldn't. We'll finish up with some choc tox, and then we've got plenty of time for questions. So why is chocolate toxic? The active toxins are theobromine, which dogs are quite slow to metabolize, and caffeine in chocolate. So these cause a receptor blockade that you'll get your CNS and cardiac stimulation. So your phosphodiesterase inhibition, you'll get cyclic AMP increasing, and this is where you get your arrhythmias. You get tachycardia, arrhythmias, and seizures. And you get an increase in intracellular calcium, causing that tremors and excitability. And it can cause some diuresis, where you'll get polyuria and fluid shifting and electrolyte losses. The clinical signs really vary from mild. They'll just sometimes have some mild GI upset, a little bit of polyuria, and mildly tachycardic. Those generally get through with just some supportive care. Moderate signs of toxicity is they start getting more tachycardic than sustained tachycardia. Still normal sinus, they're not going into arrhythmias. And they've got some they've got GI signs present, and they can be tremoring and hyperexcitable. They're kind of like little dogs on speed, really. The severe toxicity, which is life-threatening, these are dogs that have got into a lot of dark chocolate. They can have ventricular arrhythmias, they can seizure, they get themselves very hypothermic from seizuring, and they can die of it. To be honest, a lot of them we see are the mild to moderate toxicities. Every now and again, I'll get a severe one. Go through the timeline of CHOC tox is the early signs. This is even if you've had a really large dose of it. You may actually, the GI signs come first, and restless, panting, polyuria, polydipsia, and then as it progresses over time, you'll start getting the tachycardia and arrhythmias. And this is if we haven't had the chance to do, the owner didn't know, and they came back home and found them, and they've eaten a whole heap, and it's been a long period of time. So we're not going to have any merit in decontaminating. But even with chocolate, I find making them vomit up to 6 hours post-ingesting can be quite rewarding. But just to show you the timeline of toxicity, and it does take potentially up to a day for the severe signs when you've had a lethal dose. And especially if they've been the chocolates in wrappers, it takes longer to absorb. So if it's under 6 hours, I'm going to make them vomit. If they're really severely affected, you could use gastric lavage. Activated charcoal, because it's intrahepatically recycled, so we definitely keep repeating the activated charcoal. We try and we've got a brand that doesn't have sorbitol in it. It's the sorbitol that causes the hypernatremia on repeat dosing. So again, basics. To start with your A, B, C, D, E, you're going to give IV fluids. This is the one time we may actually put in a urinary catheter, because the bladder will reabsorb the toxin as well. So we keep that bladder empty, or we frequently walk them for urination. They're sometimes so hyper. Sedation, we find butorphanol's quite good in them. And we give tremor or seizure control. You can use your benzos or methocarbamol if you've got access to that here. Levetiracetam or phenobarbital. At severe end of the spectrum, you give propofol. We've got them on ECG monitoring. We're catheterizing the bladder to kind of decrease any further of reabsorption through the bladder wall. And we treat our arrhythmias. So if you've got VTAC, this is the one I showed before, really fast, uniform ventricular rhythm. Or if you've got this R on T, you can see here, this where it's depolarizing. We'll go through this tomorrow more in ECG, and repolarizing at the same time. That could go into a ventricular fibrillation rhythm, and so that's an indication to treat with an antiarrhythmic with lignocaine. So IV sterile lignocaine, we get the little vials that aren't that big multi-use vial. If all you have is a multi-use vial, and you can give that patient a fresh vial, well, great. But I have used the multi-use vial before, but ideally the IV sterile formulation. In that Betapedia site with the free protocols, we've got all of these in our drug. We call it the Red Book. There's a cheat sheet of drug doses and CRIs. Our cardiologists like to give 1 to 2 mg per kg slowly over 30 seconds, and we repeat every 5 minutes up till an improvement of rhythm, or up to 8 mg per kg, whichever comes first. And then they go on a CRI of 40 to 80 micrograms per kilogram per minute. If they're in SVT, supraventricular tachycardia with rates over 200, we're going to try and slow that right down with beta blockers. Esmolol's the IV one that we most commonly use. I always go and look the dose up in plums, because it's not a dose I keep in the top of my head. So key take-homes, you want to stabilize these patients first, decontaminate them if indicated, activated charcoal if it's intrahepatically recycled and absorbed by activated charcoal. Vitamin K is IV, is rapidly effective, so if you don't have that here, I'd try and source it. And chocolate dose and time and severity, I'd put this in a CHOC tox calculator, because sometimes they As I said, they don't need decontamination all the way through to life-threatening. The other extra thing I just thought of this morning, so I've put it on the bottom here, is @Dove. I don't know if anyone's heard of @Dove or been on it. It's a great resource. It's reasonably expensive, but it's got so much hands-on videos of how to do things. It's really practical. We keep a subscription for our full nursing team. It's in the middle of the night if they need to set up continuous suction or something they don't do commonly. You go on and click on the video of how to do it and it can show you. So it's a really great teaching platform for learning by watching active videos, putting a chest drain in, doing your first tracheostomy, things like that are all on there. But there is a lot of content. The other place I thought of too that you guys find beneficial might be Myla, the company Myla that makes all the chest drains. They've got lots of videos on how to do different things. So that's another one, a great resource. A couple of minutes for questions. No questions. We're going to put them all together for 10